I'm Dr. Benjamin Levy. I'm an associate professor at Johns Hopkins School of Medicine. I'm also the clinical director for the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. One of the hardest, one of the most difficult challenges as an oncologist is when we're talking to patients who are truly ineligible for therapy, but still want some sort of treatment. And I run into this scenario almost every week. And I think the first thing that we have to remember is that we're all in this together, and this is a shared decision making. And we always want the patient to participate in the care. And I always tell patients that this is a shared decision making when we move forward, not only for deciding whether patients are eligible or not, but other types of therapies as well, including clinical trials. I think the first thing that as an oncologist we have to do is truly define why this patient is not eligible or can receive some sort of treatment. Because treatments these days can be very nuanced. So we're not just talking about chemotherapy, but we're talking about targeted therapies, we're talking about immunotherapies. And patients obviously are becoming very savvy and understand that there are different therapeutic options, and some are potentially less harsh than chemotherapy or targeted therapies. But I think at the very onset of the discussion, I try to have a conversation as to why I feel this patient is ineligible for treatment. More often than not, these patients have exhausted the better tolerated, more efficacious treatments like potentially immunotherapy or targeted therapy. So then we're talking about chemotherapy, probably 80 to 90% of these conversations. And I try to define for them why I don't think that they are eligible for treatment. And one of the things I say is that, we look at something called performance status, and we try to measure the patient's fitness through performance status. And patients, we know this has been published literature that would suggest that patients with an ECOG performance status 3, these patients actually do worse with chemotherapy than do better. And I often tell them that the pledge I took in the Hippocratic Oath that do no harm. And when a patient's in my office saying that they want treatment, but I actually have data that says that based on their performance status, that treatment may actually do harm and shorten their life rather than lengthen it, I think it's that resonates with patients. It's oftentimes hard, but more often than not, it can resonate. I think the more difficult discussions are about immunotherapy and targeted therapy. Obviously, there's very few patients that, no matter what their performance status is, that I would not try at least a targeted therapy if they have the right target. Immunotherapy is somewhere in between. Patients who come in who have not received immunotherapy, which is rare, that's a harder conversation to have. But I think most of these conversations that I have are with patients who've exhausted immunotherapy or targeted therapy, and we're looking at chemotherapy. The other scenario where I find myself in the theme emerges of why can't you treat me, and how do we navigate this, is when a patient is wanting a clinical trial. And it's a similar unfortunate circumstance where a patient is not fit enough to be a part of the clinical trial or will not be able to make the appointments. But generally, clinical trials unfortunately do have some challenging inclusion-exclusion criteria. Most of them do not allow patients with ECOG performance status 2 or 3. That's not to say they shouldn't. It's just most of them don't right now. So I think that those are probably the two common scenarios that I work with. And again, the one thing that I would say is that I want to do no harm. And if I've got data to suggest that patients with the performance status could not tolerate the treatment, I tell them that there's a good chance that I may actually worsen things rather than improve them. Very hard discussion to have. Every physician, I've learned so much from different physicians on how to handle these cases. We often employ the social workers, our navigators, our palliative care team. Remember, patients who get referred early to palliative care actually live longer. And so we've got that data as well. That's one piece I tell them, that we've got data published in the New England Journal of Medicine to suggest that that patients who have early palliative care do better than those who don't. So those are the two messages I generally bring together, the palliative care piece, as well as do no harm piece. And I think those are probably two of the major tenets that I will use continuously in my clinic for these types of patients.